Hello everyone. Hopefully you are ready to see. My slides are visible, na?
Yes, yes, it's
Okay,
visible.
okay, okay. So I will go through the only the basics of transesophageal echocardiography today, and slowly for every classes we will deep into much more complex scenarios. So at first we'll have to know about the probe that we use. This is the probe. I will be using a laser pointer. So this is the probe. This is the T probe. It has a control housing. This is called control housing, and this is called a gastro probe. This gastro probe has a length of 110 centimeter for your adult population. And in case of pediatric, you can see in these images there are multiple pediatric options right now is available. So that's length is around 88 centimeter. It starts from 75 centimeter and goes up to 88 centimeter. And you can see the tip of the uh, this TE probe. It also houses the lens of the probe, which has the ultrasonic piezoelectric crystal. So these crystals actually are they emits the ultrasonic wave. So these are actually creates the image of what you see in the monitor. So you can see that these are actually there are almost 3 to 4,000 of crystal elements for in a case of 3D uh, probe, whereas it is only 32 to 40, 64 crystal elements for your 2D probe. And in case of in your this control housing, you can see there are a large wheel and there is a smaller wheel, and there are two switches and there is a lock. We will be describing much more in the coming slides. Right. So we have to, while putting the TE probe, we'll have to be very much cautious about where we are putting it. It will be put it in the our esophagus. So there is a multiple area where we can do trauma to the patient. The first is the your oropharyngeal, oral, laryngeal, and esophageal and gastric level. So these are the level at which we can do much of a trauma, and we can also we have to be very much cautious about while we are pushing through a anesthetized patient, where the patient will not tell you anything whether the patient is having any pain or anything. If you are having any resistance, if you are feeling, that means that T probe is obviously it is hitting somewhere else. That means it is mostly it is hitting in your piriform fossa, it is left or right piriform fossa, or it can roll over your tongue. If the patient has a larger tongue, it can roll over your tongue like this, and it can bend on the tongue, and it can traumatize your posterior pharynx. So up to 2013 guideline, there was around four levels of TE imaging. That was your upper esophageal, mid esophageal, transgastric, and your deep transgastric. But in the 2021, in the event of your recent advances in structural heart intervention, there are deep esophageal is another in between your mid esophageal and transgastric. There is another level of your imaging that has been added to the guideline, and these are the possible movements that occurs through the probe, and these all are the movements that are necessary for your the image formation and your for all the structures visualization. So you can, yeah, this is, if this is the probe, you can turn it to the left to see the left sided structures even better, and you can turn it to the right for the seeing the to the right sided structures. You can withdraw, and if you can advance, and you can anti-flex, and you can do a retroflex. There is a flexion to the right and flexion to the left. So always remember, these are the uh, so this large wheel, these are responsible for your anti-flexion and your retroflexion. So always remember, if you anti-flex it, it will if you just make it a clockwise rotation, it will be a anti-clock anti-flex uh, anti-flex movement, and if you do a counterclockwise movement, it will be a retroflex movement. And also in case of your smaller wheel, if you do a anti-flex, that is counter clockwise movement, it will be a right flexion, and if you do a counterclockwise movement, it will be a left flexion. And this is the knobs for your changing your omniplane angle. So this is the omniplane angle. Usually whenever in a neutral condition, the omniplane angle will be activated on your from your 0 degree to 180 degree. So this will be your omniplane angle. So at the 0 degree, if we move rotate forward, that means if we press on this switch, so that means the angle will be changed to towards 90 degree and forwarded to up to 180 degree. But if you just press on this switch, so this will be your rotate back to 90 degree and back to 0 degree. So this is your rotation forward or forward rotation, this is your backward rotation. So the image formation in your screen, you have to be very much careful what the angle you are seeing it. So you can be this is very important when seeing a particular structure, it will be very much relevant. Suppose if when you are seeing a four chamber view in a multiplane angle of 0 degree, your patient's right will be formation on the left side of your image, and the patient's left will be formed in the right side of your image, the right side of your screen of the image. Wherever in your just in your if you do the multiple angle 180 degree, then patient's left will become the image's left and patient's right will become the patient's right. But whenever it becomes a multiplane angle 90 degree, here it becomes a bit more confusing. Your then your inferior, whatever is towards your patient's leg will be visible on your left side of your image, and whichever is anterior or superior or cranial to the patient, it will be which will be visualized to the right side of the image. So currently in our scenario, so this is the 30 views of comprehensive TE examination. So right now there are not 28 views. Right now there are 30 views of comprehensive TE examination. Don't get intimidated by seeing this very big list. So I'll be discussing each and every view one by one. So out of this 30 views, we will be just dividing the entire views into, at first will come at the basic TE views. So what is the basic TE views? At the year of 2013, 2011, there was 11 views that were selected for the perioperative views, that these views are most important and most relevant for your perioperative views and your decision making for the patient. The first view was mid-esophageal 4 chamber, second view was mid-esophageal 2 chamber, third is mid-esophageal long axis view, mid-esophageal ascending aortic long axis view, mid-esophageal ascending aortic short axis view, mid-esophageal aortic valve short axis view, mid-esophageal RV inflow outflow view, mid-esophageal biocaval, transgastric mid short axis view, and descending aortic short axis view, and descending aortic long axis view. These 11 views, if you come just even if today, if you do these 11 views are more than sufficient to give any decision in your perioperative views. But be very much informed that these views are not adequate for your comprehensive TE examination. So in the year of 1999, there were the guideline at first published 20 views of TE. These 20 views consist of the 11 views that I have already discussed. So what are the views that were added later on? That is the mid-esophageal mitral commissural, then mid-esophageal aortic valve long axis, then the mid-esophageal RV inflow, then transgastric two chamber, then transgastric long axis, and then transgastric vessel short axis, and deep transgastric long axis view, and upper esophageal aortic arch long axis and upper esophageal aortic arch short axis. So these 9 views are added with the basic views to made up the 20 views of TE. So this is a very helpful image. And also I have to make a note to everyone that whatever the degree that you will learn while doing the TE examination and in various textbooks, or be always informed that whenever you are dealing with the patient's heart, that the heart you are dealing with, it is not a normal heart. That is why the patient is getting operated. So the patient has some pathology. So always be informed that these particular degrees, the omniplane angle that are mentioned in everywhere, it is actually an average degree of omniplane angle. So whenever this image, the better image can be found anywhere between 10-degree back and 10-degree forward. So always be very much flexible about the degrees wherever the image is being formed. So whenever this is a this is the chart that has been made from the Toronto General Hospital. So whenever you come from the hypopharynx, and if you go down into the esophagus at about 30 centimeter of depth, you will get the first view, that is your mid-esophageal fourth chamber view. That is your 0 degree of omniplane angle. So if at 0 degree of omniplane plane angle, while focusing on mitral valve, if you do change the omniplane angle to around 40 to 60 degree, you will come into mid-esophageal mitral commissural view. And then if you while focusing on the mitral valve, if you change the omniplane angle at around 80 to 100 degree, that is around 90 degree, you will get the mid-esophageal two chamber view. And at the mid-esophageal two chamber view, another 30-degree add, you get the mid-esophageal long axis view. I will come into each and every view on this image that you are seeing right now. Then uh, if then just above your mid-esophageal fourth chamber view, if you just withdraw a bit, you will be able to see the mid-esophageal five chamber view. At the mid-esophageal five chamber view, while focusing on the aortic valve in the or the LVOT in the middle of the screen, if you change the omniplane angle to 30 degree, you will get the mid-esophageal aortic valve short axis view. Then to mid-esophageal RVOT inflow outflow view, that is your at the 60 degree to 80 degree. Then at about 120 degree, it is mid-esophageal aortic valve long axis view. So just be remembered that mid-esophageal long axis view and mid-esophageal aortic valve long axis view, so these views are only in a gap between your just your withdraw and your uh, 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 if you withdraw it from your mid-esophageal long axis view, you will get the mid-esophageal aortic valve short axis long axis view. Sorry. So at from the mid-esophageal fourth chamber view, if you just rotate your probe entirely to your towards your back, towards the patient's back, that means you will get the mid-esophageal descending aortic short axis view. You will be able to see the short axis of your descending aorta. Then if you make it just 90 degree, you will get the mid-esophageal descending aorta long axis view. And from your descending aorta short axis view, if you withdraw the TE probe, then you slowly you will see that whenever the cross section, the round cross section of the your abdominal descending thoracic aorta will change into a elliptical shape. That will be your upper esophageal aortic arch long axis view. And if you change it to 90 degree, it will give you a short axis view. Then from the mid esophageal fourth chamber view, if you if you just increase the depth and enter into the stomach, the first view it will be visible to you, it will be a transgastric basal short axis view. Further down and antiflex, you will get the transgastric mid short axis view. Then transgastric mid short axis view, while focusing on your left ventricle, if you change the omniplane angle to 90 degree, you will get the transgastric two chamber view. Then after changing it to another 30 degree, you will get the transgastric long axis view. Now the from transgastric long axis view, if you rotate toward the TE probe towards your right, then you will be able to see transgastric RV inflow view. Now from transgastric mid short axis view, if you further go down and you antiflex even more, you will get the deep transgastric view. So this is the total schematic of getting all the 20 views that you are getting. But I will be discussing another 8 views that is 28 views, and the further another two views, that is 20. So what are the extra 8 views among the 28 views that we'll be discussing even more? That is your, what are the, these are the 8 views that has been added to the guideline in the year of 2013. That is mid-esophageal 5 chamber view, then mid-esophageal modified bicable tricuspid valve view, then mid-esophageal left atrial appendage view, then upper esophageal right and left pulmonary veins view, then mid-esophageal right pulmonary vein view, transgastric RV inflow outflow view, and transgastric RV basal view, and transgastric apical short axis view. So we'll be discussing each and every view one by one. So this is the mid-esophageal four chamber view that you are seeing. That means you can see the four chambers of the heart that you always remember, always try to find the meaning of this each and every view. That is the easy way to remember each and every view. So this is your left atrium, this is your left ventricle, this is your right atrium, this is right ventricle, this is your tricuspid valve that you are seeing, and this is your mitral valve. But always remember why it is a four chamber view and not a five chamber view, because none of the LVOT or your aortic valve is being seen. And also be remembered, it is always a four chamber view only when you can see the apex of your heart, LV. So a little bit of retroflexion will help you to get the better image of your LV apex. So this is your mid-esophageal commissural view. So if we focus on this is the previous view. Uh, just a minute. If you focus on this mitral valve and you change the angle to 60-degree around, you will see this image. So this is the commissural view. So this commissural view actually gives a it is a seagull appearance of your entire mitral valve, and this is this is your three scallops of your mitral valve. Can anybody tell me which are the scallops that we are able to see here, over here? Anyone? Let me see once.
P1, A2, B3.
Hello? Hello? Pardon? Please tell it again.
A1,
Can
B1, A2, P3, sir.
I'm unable to hear you clearly.
B1, A2, P3.
Okay, okay, okay. I got it. Yeah, yeah. Okay.
Um, Left to right.
Yes, yes, yes. Now, this is your mid-esophageal two-chamber view. The next view we are talking about, while focusing on the commissural view, if we change the angle to around 80-degree to 90-degree, you will get this view. So in this view, this is very important. You can see that this is the entire thing, that is your anterior mitral leaflet and your single scallop of your posterior mitral leaflet. So it is a A1, A2, A3 followed by P3, and you can see there are a small artery that you can see, a cross section of artery. That is your left circumflex artery that you can see over here, and this is your LA appendage that you can see. And here the mark you can see over here, this is your coronary sinus, cross section of coronary sinus. Now this is your mid-esophageal long axis view. Now I want to tell you one thing about this. This mid-esophageal long axis view and the mid-esophageal aortic valve long axis view. Well, everyone gets very much confused over these two views, but always remember the mid-esophageal long axis view, your focus point will be your mitral view valve. So this is a view for your mitral valve examination. So this is a view for your mitral valve Doppler examination. Any particular continuous wave Doppler and or pulse wave Doppler, whatever you are putting it, it is the best view to put the through this valve. So this is the actually this is a view for your mitral valve. So that is why the center of the image will be found by your this mitral valve. So whenever you will get this kind of image and you will be asked that whether what is the view, always see what is the center of the image is being formed. So this is a mid-esophageal 5-chamber view, and you can see that this is your LVOT, and here this is your aortic valve. So that is your 5-chamber. The what are the 5 chambers? That is your left atrium, left ventricle, LVOT, RV, and your this area you can see your right atrium. Now you can see your moderator band nicely over here. So this is your mid-esophageal aortic valve short axis view. So this is a enlarged image. Always remember in this view, our focus of image is your aortic valve. So that is why the depth of the image has been decreased to 9 centimeter. So you can see that there is an enlarged image of your aortic valve. So what are the leaflets that you, how to identify what are the leaflets? It is the most easiest way. Always remember, if this is your the most posterior part, that you are seeing it from the your posterior part of the heart, that is your posterior side of your heart. So that means you are seeing it from the back side. So this scallop, which is just opposite to the scallop, so it is the most anterior scallop. So that means it has to be a RCC. And another thing always to mention, that the scallops which actually corresponds to your interatrial septum, it is always your it is always your what is the leaflet?
Non-coronary cusp, NCC.
Yes, it is a NCC, non-coronary cusp, and the rest of the cusp which is left, it is a left coronary cusp. So this is your mid-esophageal RV inflow outflow view. So like previous image, this also creates a confusion whether it is a in your various examination, it has been asked whether it's a view of your aortic valve short axis or whether it's a view of RV inflow outflow view. So always remember, the if the say whenever you will be able to see RVOT, and whenever you able to see RV, that means it is also an image of RV inflow outflow view. Always remember, in this view you can see a part of the RV inflow, but you cannot see the part of the RV outflow. But here you can see the RV outflow also. And also the focus of the image and the depth of the image you can see over here, it is around 13 centimeter. That means it is to see the distal part of your field of your heart. So this is your right atrium, this is your tricuspid valve, this is your right ventricle, this is your pulmonary valve, and this is your pulmonary artery that you are seeing right now. Now this is a mid-esophageal aortic valve long axis view that you are seeing. Now you can see that you cannot see the entire mitral valve. But your focus of the image is the aortic valve and its movement. So this is your aortic valve long axis view. Now comes it's a very important image. It's a mid-esophageal bicaval view to see for any cannulations and also to see your AST and all the flows around it. So this is your SVC, this is your right atrium, and this part is your right atrial appendage that you can see, and this is your your IVC, and this is your left atrium, or it is interatrial septum that you can see. Now this is your mid-esophageal modified bicaval tricuspid valve view. While mentioning this view, whenever you are being asked in your any examination what is the name of the view, always don't forget to mention that this is a tricuspid valve view, because this is a view to see the tricuspid valve. The purpose of the view is for the tricuspid valve. So always to mention the complete name, that is mid-esophageal modified bicaval tricuspid valve view. So while tricuspid valve view, we can see that if you increase the omniplane angle to around 110 to 120 degree, you will be able to see the tricuspid valve. And tricuspid valve, and you can, if there is any TR, you can put a direct Doppler through it. So you can do a very good Doppler examination through this. And the vessel you are able to see. Can anybody name what is the vessel you can see over here? What is the name of this vessel?
IVCs.
No, this is not IVC. This is coronary sinus. This is the coronary sinus. This is a also a view that is very much useful while doing a coronary sinus cannulation. If you are doing a coronary sinus cannulation, this is a view that is a very much useful view. Now, this is a mediasophageal ascending aorta short axis view. So, if while focusing on, so how to bring it this view? So, while focusing on your aortic valve in a short axis view, if we withdraw your TE probe a little bit, you will be able to see a short axis of your ascending aorta. So this is your ascending aorta, and you will be able to see your main trunk of your main pulmonary artery over the right side of your image. And what are the this vessel? This vessel you are seeing, it is your right pulmonary artery, and this vessel you are seeing, it is your SVC. This is the pulmonary valve that you are able to see. Now, while just focusing on this image, if we change the omniplane angle from 0 degree to around 90 degree, you will be able to see the long axis of your ascending aorta. So this is a mid-esophageal ascending aorta long axis view. So, and then you will be able to see a short axis of this vessel. What is this vessel? This is your RPA, that is right pulmonary artery. And what is this vessel? This is your SVC. Now, mid-esophageal LA appendage view. Now, this is a little bit of modification of what views you have already seen. It is actually a view that is your mid-esophageal two-chamber view. Huh? It is a mid-esophageal two-chamber view, but your focus is towards your LA appendage. So, you have to decrease the depth, and also you have to rotate it towards the left so that your LA appendage becomes much more prominent and it comes to the center of the image. Now, while discussing your pulmonary veins, it is absolutely important to remember that the pulmonary vein, it is as a venous structure, it is extremely different in every person. So you will not get a particular pulmonary vein at particular angle. So whenever you will find any difficulty while doing a pulmonary vein, so always try to find the LA appendage. So if you are finding the LA appendage, you will be able to find where is the coumarin ridge. So this is your coumarin ridge, and around that coumarin ridge, you will be able to see the left upper pulmonary vein. So left upper pulmonary vein, if you and how to identify a pulmonary vein? It is a only vein and only artery which is being, it's a typical colored Doppler flow that you will be able to see like this in your pulmonary vein. That always remember, you don't identify your SVC, IVC or your aorta by seeing a colored Doppler, but you identify your pulmonary vein by seeing the colored Doppler only. Otherwise, you won't be able to justify whether it's a pulmonary vein or not. So ideal colored Doppler scale, if the patient has a normal pulmonary vein or normal mitral valve, a normal heart you are dealing with, that means your pulmonary veins, your colored Doppler scale should be around 30 to 40 centimeter at max. So this is your left upper and left lower pulmonary vein at 0 degree. So if we further just withdraw the probe, you will be able to see the both the pulmonary vein over here. So this is your ascending aorta. This is your SVC that you are seeing. So in your ascending aorta mid-esophageal short axis view, if we rotate the probe towards your right, you will be able to see mid-esophageal right upper pulmonary vein, which will be entering into your atrium. And this is mid-esophageal right upper pulmonary vein at 130 degree. That means in your modified bicaval view or your bicaval view at least, if we rotate the probe towards your right, then also you will be able to see that there is a colored Doppler you will be able to see. So this is your right upper pulmonary vein at 130°. So always remember this is actually different in every patient. So particular angle, it is not possible to say that this patient will have a pulmonary vein at this angle for all practical purposes. So pulmonary vein you'll have to find it like this only while putting the colored Doppler. The but the for easiest way that I always follow, that whenever you will be able to see that your you will get a uh, you will want to see the left sided pulmonary vein. uh, Wait, let me show you once. Uh, so from the bicaval view or modified bicaval view, if you rotate your your probe towards your right, you will be able to see the right sided pulmonary vein view. And also from your ascending aorta, if you rotate it towards your left, you will be able to see your left sided pulmonary vein. So this is your upper esophageal aortic arch short axis view. So this is the upper esophageal, this is your aortic arch short axis, and this is your main pulmonary artery trunk. So if it is seeing a main pulmonary artery trunk, you will be able to see. So this is your pulmonary valve. And if you this is the particular view, it is very much useful to put any color Doppler or any pulse wave or continuous wave Doppler on your pulmonary valve. So that you can see a proper waveform, you can see over whether the patient is having any pH or not. It will be able to understand with from this image. So if you want to put a pulse wave or continuous wave Doppler on pulmonary vein, sorry, pulmonary artery or over the pulmonary valve, so this is the best view for you. This is the upper esophageal aortic arch long axis view that I was discussing. Now, can you tell me that we without putting colored Doppler, can you tell me that which side is your proximal and which side is your distal?
Left side is proximal, right side is distal.
Which side is proximal? Hello.
Anil Gupta said left is distal.
Acha, left is distal. Okay.
Anil Gupta
Acha.
has posted. Yeah.
Now, acha, I want to show you a simple thing. Just hold on. Because this is the basic things you have to be very much correct and very much clear. I'm going to one of my previous slide. Huh. So in this image, in a 90°, in any image, if you see, this is your inferior and this is your anterior. And at the 0°, this is your patient's right, this is your patient's left. Now go back to that image. Now it is clear. What is this view? This is a transgastric basal short axis view. So this is the view where you will be able to see your mitral valve, and this is the best view for your mitral valve planimetry. This is the view. I have already told you that this view, it is a from fourth chamber. If you go advance the probe towards your stomach, and if you just antiflex it after entering the stomach, the first view that will come into view, that is your transgastric basal short axis view. And if you go further down and antiflex, you will get the transgastric mid papillary short axis view. Now this is a further down, you will be able to see transgastric apical short axis view. Now the you can see that in the mid papillary you will be able to see the papillary muscle. This is your anterolateral papillary muscle, this is a posteromedial papillary muscle, and further down you are not able to see any papillary muscle over here. So this is your apical short axis view. Now this is a transgastric two chamber view. So this transgastric two chamber view, you will come from this image. So while focusing on this LV, if we just change the angle to 90 degree, sorry, then you will be able to see this view. This is your left atrium, this is your mitral valve, and this is your left ventricle. Now it's a nice thing that you can see what are these that you are able to see. These are the chordae. These are the chordae of the mitral valve. So this is the best view to see whether the chordae are calcified or not, and whether there is any caudal tear or not. So you can actually do a very good examination of the chordae and its anatomy from this image. You can see and also measure the caudal length if there is any neocaudal surgery is being planned. If you change the multiplane angle to 120 degree around, you can see your aortic valve opens up like this. So this is your aortic valve, and this whitish thing that you see, it is a chunk of calcium in this patient that you are seeing in the LVOT. Now from this 120 degree, this previous image, if we rotate the probe towards your right, then you will be able to see your right atrium, tricuspid valve, and your RV. So this is your transgastric RV inflow view. Now while transgastric RV inflow view, if we do a right flexion, then you will get this view, that is transgastric RV inflow outflow view. Or you can do another maneuver. You can change the omniplane angle to 120 degree, then also you will get a mirror image of the previous image. So this is a transgastric RV inflow outflow view at 120 degree. So this is, here you can see this is your right atrium, this is your tricuspid valve, this is your RV, and this is your RVOT. This is a pulmonary valve, this is a pulmonary artery. Now this is a transgastric RV basal view. So at your mediasesophageal RV, that is basal short axis view, if we rotate the probe towards your RV, that is towards your right, that will you will able to see your short axis of your tricuspid valve. So this is your RV basal view. Now this is a deep transgastric view. In the if you go further down, you will be able to see This is a 5 chamber view. But in this image, in this particular video, you are not able to see any other two chamber, any right sided chamber you are unable to see. But otherwise, it is called deep transgastric 5 chamber view. So this is your one chamber, this is your two chamber, this is your three chamber, and the right sided chamber forms the 5 chambers. So this view is very much useful for your Doppler interrogation for your LVOT and also your aortic valve. Now these are the views that has been added recently at 2021. It is called deep esophageal view. Deep esophageal view means it is in between your mid esophageal views and your transgastric views. So in your mid esophageal views, if we go further down, you will be able to see the coronary sinus. Why it is very important? Because it is for your tricuspid valve. If you do any intervention on your tricuspid valve, then you can see that in your 4 chamber view, what are the main chambers that you can see? It is your left sided chambers, that is your left atrium and left ventricle. But if we go a little bit of down, when you will be able to see coronary sinus, then your left sided chambers are actually vanishes from your images. So your right sided chamber becomes much more prominent. So that is how you can see more of your right sided chamber, and you can see your tricuspid valve even better. So that is how this deep esophageal views has come into the guidelines. So you can see this is your anterior leaflet, and this is your posterior leaflet, this is your RA-RV, and this is your coronary sinus. And there are two views, that is deep esophageal RV inflow view and deep esophageal RV inflow outflow view. But if you want to give deep esophageal RV inflow outflow view, you will have to use a special software, that is your biplane software. So if we put a biplane through this, you will be able to see your inflow outflow view. So this is your RA, this is your tricuspid valve, and it is your RVOT, and this is your aorta. So these are my references, and further discussion I will take over on from your next classes. Thank you. If there is any question, please feel free to ask me. And if there is anything, if you want to discuss even more, I will be happy to discuss in your uh, upcoming classes as well.
Thank
Okay.
you, Abhinandan, for excellent and elaborate discussion.
Thank you. There is a
And
question, I guess, how to differentiate coronary sinus and IVC in your bicaval view. Acha.
yes,
Acha. Now, I want to just be very much clear about whenever coronary sinus and in your bicaval view, just let me to go to that image. It will be easier for you to understand. Usually, the IVC is much more uh, wider, and your much it has a larger diameter than your coronary sinus at first. Second thing, if you trace it down, there will be a junction of your hepatic vein draining into that IVC, but there will be no hepatic vein draining into your coronary sinus. So coronary sinus is usually much smaller than you, unless and until the coronary sinus is hugely dilated in due to other congenital pathology. But otherwise, coronary sinus is much smaller diameter than your IVC.
yes.
Acha.
And liver can be seen
Exactly, sir.
towards IVC.
Yes, sir. Yes, sir.
One more question. Aortic
Arch
arch
long axis
long
view.
axis view. Which side
Which
is
side is
proximal?
proximal? Acha.
Okay,
Which
once
side?
again.
Uh, uh. So if we come the how the image is being formed. So whenever you are coming it from your descending thoracic aorta, short axis view, you are withdrawing and you are suddenly getting this image. So suddenly, if you are suddenly getting this image, usually this is your proximal and this is your. Can you see my pointer? I guess.
Yes, yes.
So
It's
this is
good.
your proximal and this becomes your
Distal.
distal. And here you will be able to see your subclavian artery also, just before the aortic arch.
One more question. Aortic arch anterior and posterior as well. Is asking. Which side is anterior, which side is posterior?
Which side is anterior, which side is posterior means, but I'm not, unable to understand what exactly is asking.
Anterior wall of maybe
Acha.
arch anterior wall
Now,
and
now always,
posterior.
always remember, if you are seeing it as a 0 degree, that means you are seeing it from the back side. Now, so this is always your posterior wall. This is your
Yes.
anterior wall.
So I think it's clear now.
Vendra, are you? Is it clear?
So
Exactly.
towards probe, it's a
Yes,
posterior.
yes, yes. That madam will share in the group.
Yeah, Dr. Mona Lisa will be sharing
Yes,
again.
thank you, Abhinandan. It's excellent class.
Thank you,
Really,
ma'am.
you have made here the difficult topics to make easier to understand for everyone. And thank you everyone for being a part of our today's session. We'll be sharing all the details the next 6 classes and what will be the topic. If you want, we can share it along with the flyer, all the topics that we are going to discuss, or the week by week as we are going through the from the beginners to advanced stage of the T. So this is just a beginning of our journey into the world of transesophageal echocardiography, from the understanding of the basics to mastering of the advanced insights. So Abhinandan will take all the classes so that he can make you go through that journey. So that he can make this journey very pleasant and very easy to all of you. So your presence truly adds a value to this learning community. So we'll be looking forward to seeing you again next Saturday at 7 p.m. Thank you. Thank you very much to all of you. Thank you, Abhinandan. Ravi sir, please.
And
Thank
sorry,
you.
Abhinandan, in the beginning, I was somewhere outside and unable
No,
to
not an
introduce
issue,
you.
sir. Not an issue, sir.
Everybody knows you, and you're such
Okay.
a good teacher.
Thank you.
So, and thank you for taking time out and
Thank you, sir.
sharing all the knowledge. Thank you.
It's an honor.
And thank you all
And
the participants.
another just someone has asked Dr. Raj, Ranjani is asking us that could you please share the recordings of Zoom? Yes, yes, definitely we will be
I will be
recording
sharing soon.
all
Yeah,
the
you
Zoom
can
meetings in the
go through
middle of the next week.
our YouTube channel and you will find it.
For all the
YouTube
Heartline
channel of Dr.
classes,
Only Akhtar.
yes, every classes is recorded and available for all of you in our YouTube channel. Okay, thank you very much. YouTube channel name is IACTA West Bengal. WBIACT IACTA West Bengal. Okay, we'll be sharing the YouTube channel name and the link to all of you. Thank you very much. Thank you.
Thank you. Thank you. Thank you. Thank you.
Thank you, everyone. Thank you.
Thank you. Thank you.
Bye bye.
Good night, everyone.